welcome to our third episode or our third video on GMDC internal medicine. So let us not waste much time. Let us zoom in so we have a 26-year-old alcoholic who was brought in with jaundice, abdominal distension, bipedal edema. He is also noted to speak incoherently occasionally over the past 2 days. Patient is said to have had a seizure few hours to presentation, but currently conscious. Examination revealed that the patient had hysterexis. The patient had hysterexis. That's more like how do you call it? Tremors, okay, on the hand. Tremors on the hand, especially when extending it. Good. So basically, this is our situation. So we are having jaundice, edema, abdominal distension, seizures, and so on and so forth. So what comes to mind? Definitely, you are going to deal with a problem with the brain. You are going to deal with what? A problem with the brain. A problem with the brain. But they've told you that this person is alcoholic. This person is alcoholic. So that means that whatever thing that the person is experiencing now is as a result of the alcohol intoxication. Okay, because for them to say is an alcoholic should tell you that this person has been drinking a lot. So perhaps abusing the alcohol, isn't it? So again, what comes to mind? Alcohol. What comes to mind? The brain. The brain. And again, they've told the person having what? Seizures. So again, this all is telling you that we are having what? A CNS manifestation. Okay. So now let's look at the questions that they will be asking us. What is the likely diagnosis in this patient? So definitely you are going to look at for what? For hepatic encephalopathy, secondary to chronic alcoholic liver disease. Hepatic encephalopathy. People who like drinking a lot, usually when people come in with this kind of analysis, like drinking or this history of drinking, you are thinking of the brain. You are thinking of what? The liver. Okay, these are the major places you begin to what? Look out for or think about, and even sometimes the pancreas. Okay, these are some of the areas you begin to look out for. So in our case, we are having what? Hepatic encephalopathy. Hepatic encephalopathy, secondary to chronic alcoholic liver disease. All right. For possible precipitants for patient's current state. So what could cause what the patient is having? Definitely you are looking out for what? For dehydration, infections, upper GI bleeding, constipation, sedative drugs, high protein diet. High protein diet. These might be the possible precipitant. Okay, again, high protein diet, constipation, upper GI bleeding, infections, dehydration, sedative drugs. You know, people who normally drink, for instance, usually they are at high risk of getting upper GI bleeding, because these alcoholic substances are very harmful to the mucosa or to the endometrial lining or to the lining of the esophagus. Okay, they are very toxic to it. So you have to be very careful. So the esophagus or even the stomach can develop, GI bleeding. So we're looking at what? Upper GI bleeding. Then of course you are predisposing yourself to infection. Okay, and that can be a result, or that can lead to the manifestation of all of these things that we are having in this question. So again, high protein diet, constipation, upper GI bleeding, infections, dehydration, and sedative drug. These are the possible precipitants. What investigations will you carry out investigations. So this is what you're going to do. Definitely, you are looking at what a problem with the liver. So you do what? A liver function test. Liver function test. You will do full blood count. You will do blood glucose. Because those who drink a lot, Charlie, they have problems with their glucose level because almost every part of the body is super active and need glucose to survive or needs energy because of your state. Okay, because of your state or your alcoholic state. So glucose could be a problem. So you can also do what? BUE creatinine. BUE creatinine. BUE creatinine. Then you can do an abdominal ultrasound. Abdominal ultrasound. Abdominal ultrasound. Again, you can do full blood count, liver function test, blood glucose, BUE creatinine, abdominal ultrasound. Abdominal ultrasound. So these are the possible investigations you can carry out. All right. How will you manage this patient? How are you going to manage this patient? So first of all, again, this yes might look more of an emergency case and stuff like that, isn't it? So you have to manage this person what accordingly. But again, they didn't mention what anything concerning that this is an emergency case whatsoever. So you can continue directly with your treatment. So over here, what are you going to do? You are going to identify and treat any precipitant. Identify and treat any precipitant. So if it is upper GI bleeding that is leading to this manifestation, immediately treat that precipitant. If there's infection, treat it. If there's dehydration, treat it. So these are the things they're going to do. So identify and treat any precipitant. Then you can give IV 10% dextrose. 10% dextrose. You need glucose. So 10% dextrose. That's what 500 mils. Then you can also give what? A vitamin B supplement. Because people who like to drink, they are having what? Hypovitaminosis. So you might want to give what? Vitamin B1. Vitamin B1. And again, this will also what? Help to prevent the seizure, and prevent nerve damage and even death. So you might want to give what? Vitamin B1, also known as what? Pabrenex. 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 So you can give IV dextrose and Pabrenex. Then you can give oral metronidazole, then lactulose. Lactulose. Lactulose helps to take away harmful substances from the body. Example, ammonia, for instance. It takes ammonia out of the body. Okay, so you give lactulose. And then lactulose also prevents constipation. It also prevents constipation. So you can give these as well. So again, identify and treat your precipitant, give 10% dextrose and Pabrenex. You can also give metronidazole, give lactulose. These will be your management plan for this patient. Management plan for this patient. All right. We have a 56-year-old woman, obese with a past history of alcohol of 20 units weekly and 3 packs. Years of smoking presented to her general practitioner 4 months ago and had a lipid profile indicating a total cholesterol level of 6.14 and a low density lipoprotein to be 3.7. She was rushed to the emergency with weakness in the right upper and the lower limbs with slurred speech. RBS on arrival is 18. BP is 180, 110. Guys, this is a patient with a history of alcohol, with a history of smoking, obese, And now the person is having what? Right upper and lower limbs weakness. So that tells you that there is a problem with the brain. There is a problem with the brain. So you start thinking about it. So this is what this could be what possible, CVA, isn't it? That is stroke. Because with stroke, you're having this kind of what presentation. I think we've solved similar question, previously. So you can be able to understand this thing. And again, look at the sugar level. 18. That is extremely high. At least don't get more than 11, or patients don't have more than 11 millimole per liters. And again, the BP is quite high. All right. So at least you have a gist of the whole idea, isn't it? Obesity, smoking, alcohol abuse. And now we are looking at what? Yeah, stroke, possible stroke. So, what is your differential diagnosis? What is your differential diagnosis? So, one, we can talk about what? Stroke, stroke with right hemiparalysis, right hemi right hemiparalysis, because everything's occurring on the right side of the limb, isn't it? Because there's weakness on the right and the lower limbs. So we can talk of CVA or stroke with right hemiparesis, secondary to uncontrolled hypertension. So that could be what? Our first differential diagnosis. Second, we can be looking at for what? For diabetes mellitus. Diabetes mellitus. Third, we can look for what? Dyslipidemia. The cholesterol level. Dyslipidemia. Dyslipidemia. So these are our possible differential diagnosis in this patient. Again, CVA, diabetes mellitus, dyslipidemia. Dyslipidemia. All right. What are the identifiable risk factors in this patient? So now look at the question. What are some of the things that are risk factors for developing the above differentials, like the CVA, like the diabetes, like the dyslipidemia? What are the risk factors? So one, hypertension is a risk factor. Diabetes is a risk factor. Diabetes is a risk factor. Dyslipidemia is a risk factor. Yes, although it's a differential, but it's also a risk factor, isn't it? Because cholesterol level is quite not good. So we have what? Dyslipidemia. You can talk about the age. You can talk about alcohol intake, smoking, obesity. Again, hypertension, diabetes, dyslipidemia, age, alcohol intake, smoking, obesity. These are the identifiable risk factors in this patient. All right. What investigations will you carry out? What investigations will you carry out? Of course, you want to do what we discussed it in our previous questions, that one of the key investigations to do for anybody suffering from stroke or CVA is what? Definitely head CT scan. So, what would be your investigation? You will do a head CT scan. But you can add more. You can do the chest X-ray. You can do the ECG. You can do although they've told us about the random blood sugar, but you can also do what? The fasting blood sugar. Fasting blood sugar. You can do glycated hemoglobin. Glycated hemoglobin. So this, if more or less like to see if indeed this is diabetes, okay? So the glycated hemoglobin is like, for example, something that has been with you for quite a long time, and it is able to detect that yes, for the past 3 months, for the past so and so month, you have been having an increased level of glucose, isn't it? So the glucose begin to bind with the hemoglobin. So we call it the glycated hemoglobin. So when we have a specific value, if it's more than that value, then we can confirm that indeed this person is having or this person is diabetic. All right. Then what other investigation can you do again? You can also do a liver profile. liver profile test, then your BUE and creatinine. BUE and creatinine. Again, you will do an urgent CT scan of the head, chest X-ray, ECG, fasting blood sugar, glycated hemoglobin, lipid profile, BUE, and creatinine. These you can do. All right. So apart from medical management, what other therapies may be employed in this patient's management apart from medicine? So this one, you want to encourage lifestyle modification or lifestyle management, which include reducing alcohol intake, stopping smoking, and exercising regularly. Exercising regularly. And we can talk about the diet therapy and physiotherapy. Again, lifestyle changes such as reduce alcohol, quitting smoking, regular exercise. Then we can talk about diet therapy and finally physiotherapy. Physiotherapy. So apart from medicine, these can be employed. These can be employed. All right. So a young woman presented to the clinic with a left leg swelling of 2 days duration. Left leg swelling. Okay. He is said to have traveled from Australia 3 days ago. Leg swelling is associated with pain. So it's a woman, leg swelling, travel history, there is pain. What comes to mind? Definitely, you are thinking of what? A problem with the deep vein, isn't it? Problem with the deep vein. Could be inflamed, anything can happen to it. So you are thinking of a problem with the deep vein. Okay. So let's see our questions. 3 possible risk factors. So sometimes when you travel for a long time, or when you sit in a car for a very long time, you realize that your leg could swell, isn't it? So long distance travel can be a risk factor. Long distance travel. You can have trauma to the leg. We can talk about previous history of deep vein thrombosis. Pelvic tumors, orthopedic surgeries, then oral contraceptive pills. So these are the possible risk factors that can lead to leg swelling. Again, long distance travel, oral contraceptive pills, pelvic tumors, orthopedic surgeries, trauma to the leg, and a previous history of DVT, deep vein thrombosis. All right. What investigations will you carry out? What investigation? Of course, if you're thinking of something like DVT, definitely you might want to do what? Your D-dimer. And again, since you are thinking of a problem with the veins, you might want to do what? A Doppler ultrasound of the leg veins. So these are the investigations you can carry out. But if you have to mention one, then go for the D-dimer. Again, D-dimer or Doppler ultrasound of leg veins. All right. So, what is your likely diagnosis? Definitely, we are looking at DVT of the leg, the left leg, to be specific, left leg, DVT of the left leg. One complications you would want to prevent in this patient. So basically, people with deep vein thrombosis, one of the complications which we encounter every day, we call it the pulmonary thromboembolism. Where the thrombus dislodges and begin to emboli, if I should put it that way, or to move inside the vessel and go and block somewhere in the lungs. That is called what? Thromboembolism. So thrombus is moving in the blood. That is the process called what? Embolism. Then it will go and block, some important passage. It can go and block some important passages, and that can lead to pulmonary thromboembolism. So what complication would you like to prevent? Definitely, you would like to prevent what? Pulmonary embolism. Pulmonary embolism. All right. So we have a 46-year-old diabetic and hypertensive man who was rushed to an emergency room with a history of syncope and constricting chest pain. Few hours to presentation, constricting chest pains. On arrival, was look at the pressure, 94/65, pulse 75, irregular. That's more or less telling you that there's what an irregular heartbeat. There is an irregular heartbeat, and you might be looking at something called what? AFib or atrial fibrillation, basically something like that, but not conclusive, anyways. Now, patient is dysphonic with SpO2 of 88. You remember I was telling you about SpO2 or the oxygen saturation. It should not be less than 92, 93. It should not be less than that value. If it is less than that value, that means this person is in a serious what? Dyspnea. Good. Now look at the random blood sugar. 23. This is high. Very high. We said at most 11, isn't it? Now we're having what's 23. So that is what is happening over here. And again, they've told you the person is diabetic and hypertensive. When they give you a disease like this, start thinking of their complications. Start thinking of their complications. And now we are having what? Loss of consciousness, which is the syncope. We are having heart problem or constricting chest pains. And we are having what? Arrhythmias. So what are we be looking out for, or what will we be looking out for? Definitely, we are looking at what? A problem with the heart, problem with the sugar, and so on and so forth. So let's dive in and see the questions that are there. All right. So what are the differential diagnoses? What are the differential diagnoses? So over here, one, you can think of acute myocardial infarction with arterial fibrillation. Acute myocardial infarction. And when there is a myocardial infarction, it leads to a constricting chest pain. And that might also affect the cardiac output. Because MI normally affect the left ventricle. And the left ventricle is involved in squeezing blood into systemic circulation. So when that place is devoid of oxygen supply, what can happen is that the muscle can become weak. They can undergo infarction or necrosis, and that can lead to a reduced cardiac output, for which probably we're experiencing in this patient. Now, what other differential can you mention? We can mention diabetes mellitus. Why? RBS is quite high. So you can think of what? Diabetes mellitus, and you might want to rule out DKA. Diabetic ketoacidosis. You might want to rule it out. Then you're also thinking of what? Pulmonary embolism. One of the causes of a constricting chest pain or myocardial infarction is when there is a blockage somewhere. For which, of course, supply is impeded. So you might want to look out for a possible pulmonary embolism. Basically, that's what we'll be looking out for. Okay? All right. What are some of the symptoms you would consider in your direct question? That's the ODQ. What questions are you going to ask? to ascertain the severity or perhaps to confirm your diagnosis. So, one, you want to know the characteristic of that chest pain. For example, what is the duration? What is the radiation? I mean, does it radiate? Does it move to the left arm? Or it is just concentrated to the heart? You also want to know the exacerbation factors. That means what aggravates it. When some people walk, it becomes severe. When they rest, they're okay. So you want to know aggravating what or exacerbation factors. Then you also want to know the relieving factors. Relieving factors. What I think that he or she will do that will make her, good. Like resting, for instance. Good. So that is for the characteristics of the chest pain. You can also do, or you can ask if there's possible nausea or vomiting, or both of them. So nausea or vomiting or both. You can talk of presence of cough, presence of autopnea, presence of autopnea. They also have the paroxysmal nocturnal dyspnea, that is waking up in the middle of the night because of difficulty in breathing. Does it happen? You want to know. Okay. Again, you also want to know if there is possible polyuria, possible polydipsia, possible polyphagia, possible weight loss. At least these will be going in for the diabetes mellitus you might be looking out for. So again, characteristics of the chest pain, the duration, the radiation, exacerbation, and relieving factors. You can think of the nausea, the vomiting. You can think of the cough, the autopnea, the PND, paroxysmal nocturnal dyspnea. You can think of the polyuria, polydipsia, polyphagia, weight loss. So these are the direct questions you will want to find out from your clients. All right. 5 investigations you will carry out. 5. Definitely, if you're thinking of acute myocardial infarction, there's no way you wouldn't do ECG. So do your ECG. So the ECG, you're either looking for what? ST elevation or ST depression. ST elevation or ST depression. Then you might want to consider what? Elevated cardiac enzymes. So if the heart is inflamed or there's a problem with the heart, there will be what? Increase in cardiac enzymes, including troponins. Troponins. Then you might want to do what? D-dimer to be able to rule in or rule out pulmonary embolism. Do your D-dimer. Again, you can do your glycated hemoglobin because diabetes is present. You can do your lipid profile. Do chest X-ray. Then you can do your echocardiography to know if the valves are having problems or not. Again, ECG to show the ST elevation or ST depression, elevated cardiac enzymes, including troponins, D-dimer, glycated hemoglobin, lipid profile, chest X-ray, echocardiography. So these are the possible investigations. Just mention any 5 and you are okay to go. What would be your management objectives for this patient? Management objectives. Now, guys, this person is having what? An emergency case for which they brought this person into the emergency room. So again, they've given you that this is an emergency case by virtue of the question even implying it. So what are you going to do? You assess and you stabilize your ABC. Then you give intranasal oxygen because this person needs oxygen. SpO2 of 88 is low. Give oxygen and monitor the SpO2 levels. Then carry out your investigations to confirm your diagnosis. Then manage your myocardial infarction or the pulmonary embolism, whatever, with thrombolytics, or anticoagulant. So you can give anticoagulant to manage this kind of stuff. You can even manage the arterial fibrillation also with anticoagulant. Okay. Of course, you can give something like aspirin as well. It can help to manage the arterial fibrillation. Then manage hyperglycemia. Manage hyperglycemia. Of course, you can give your insulin and so on and so forth. Then you monitor the BP. Monitor the BP and make sure you manage it appropriately. Make sure you manage it appropriately. But don't forget, you must also give intravenous infusion so that the BP can at least come a little bit up. But there's one thing that you must know, that when you're having BP, it is not advisable. When your patient is having BP, it is not advisable to give the person normal saline. Please, it is not advisable, because giving normal saline will increase the BP. Okay, so when somebody is hypertensive, you don't give normal saline, because it will increase it. But when BP is low, yes, you can give it, because you actually want the BP to come a little bit high, isn't it? So that's just by the way to just chipping in, so that for your practices, you will be able to know what to do when you encounter with somebody having a severe blood pressure. Don't go and give normal saline. All right, but you can give your ringers and even the DNA you can give. All right. So basically, that is it for this particular question. All right. A 38-year-old secretary presents to your consulting room with a history of recurrent boils. Patient admits to frequent water intake, guys. Frequent passage of large volume of urine. So the polydipsia, polyuria is here. Now, she frequently also has whitish vaginal discharge with itching, pruritus. But has no known history of chronic illness. No history of chronic illness. There is recurrent boil. That's furunculosis. And people with diabetes usually get this kind of recurrent boils. And again, we are having signs and symptoms that shows that indeed there could be diabetes or too much sugar. All right, so let's look at the questions briefly. What diagnosis will you make in this patient? Diagnosis, that means they might be expecting more than one, isn't it? So over here, what diagnosis are you going to be thinking about? One, recurrent furunculosis. Actually, boil means furuncle, isn't it? Or furunculosis. So recurrent furunculosis, which is likely from diabetes mellitus, because this person actually has diabetes mellitus. Then we can talk about vaginal candidiasis because of the discharge from the vagina. So we have vaginal candidiasis and recurrent furunculosis due to diabetes mellitus or secondary to diabetes mellitus. All right. What investigations will you carry out? Of course, if it is diabetes, you might want to do the glycated hemoglobin. You might want to do full blood count, fasting blood sugar. You might want to do, since we're looking at for, how do you call it? Candidiasis, you might want to do high vaginal swab. High vaginal swab for culture and sensitivity. High vaginal swab for culture and sensitivity. Then you might want to do a retro screening for possible HIV. Do a retro screening. All right, so these are the investigations you might consider: full blood count, fasting blood sugar, glycated hemoglobin, high vaginal swab for CS, retro screening. All right. What will be your immediate management? So for immediate management, you will want to give antibiotics to treat the furuncles. Sorry. Then give antifungal for the vaginal candidiasis. Then, of course, you confirm and then you manage the diabetes mellitus. Confirm and manage the diabetes mellitus because diabetes mellitus is present, which, of course, should be present. Then you can start giving your insulin depending on the value that you are what having. Then you can put the person on a permanent management plan as well. All right. So that is that for the immediate management. Again, antibiotics, antifungal, confirm and manage the diabetes mellitus. Okay. Outline your long term. Okay. Long term. So this one was what? Short term or the immediate management. Now let's talk about the long term. So long term basically deals with a whole lot of things. Monitoring the person and everything like that. So for long term, we can be looking at for what? For insulin. So you can give insulin or oral diabetic agent. So you have to put the person on maybe monthly diabetic agent or anti-diabetic agent. So agent against diabetes. All right. Then you want to do a regular follow-up reviews. Regular follow-up reviews. Then you might want to give what a dietitian review. A dietitian review. Dietitian review. Then these people normally have complications with the eye. So you might want to do what? An annual ophthalmology review. Annual ophthalmology review. So you might want to do all of these things as the long term. Then, of course, you can't forget regular exercises. Regular exercise. So this person need to exercise regularly, okay, and avoid eating late in the night and all those kind of stuff. So basically, these will be your long term management. Long term management. All right. All right. So, ladies and gentlemen, we have come yet to the end of another session. And I believe you enjoyed it just as much as I did. And again, if you have any question, please let us know in the comment section. Inform your friends, tell your friends about this great thing that we are doing over here. Let all of us benefit from it. Please don't forget to contribute. Don't forget to bring suggestions, okay? And let's move things forward. All right, until then, seeing you in the next episode.